Good morning. Welcome to Coffee and Cases. So this morning we're gonna have a chat just around some HIMSS activation criteria. But before we jump into that, I wanted to just do a few reminders. So the first is please don't put any of your details into the chat. The register will be sent out a little bit later with a keyword that you will need to be able to register your CPD points with. We try and create a really safe space for good conversation. And so it's going to be really interactive today. So we're going to ask that please, when there is a question or when there's sort of a requirement to come back with some information, that there is some engagement. And we may or may not be calling on random people in the conversation today,
Okay.
just to make sure that everyone who's actually joining is engaged. We're really happy to have you here. And this is a presentation that is sponsored. Unfortunately, I made a big mess this morning by sending out the wrong sponsorship, but it is sponsored by Lenmed Group. The hospital group have sponsored certain sessions throughout the year. And we'd just like to highlight and say thank you to the Lenmed Group for supporting and getting involved in our system. Okay, so we're going to start out just with an idea of what activation looks like for HIMSS. And I think in the recent years, there's been some changes around how we maybe make good decisions for the right patients at the right time. And the concepts that I'm going to speak about here are what we've adopted as the rocket sort of approach to activation. Obviously, speaking from only the rocket perspective, but the concept really should be the same across all the systems. We want to make the best possible benefit for the patient in front of us. We want to make sure that the patient gets to the appropriate facility, and we want to support the teams on the road and in the hospitals as effectively, but also as reasonably as possible. Considering some of the challenges in the HIMSS environment, you have a really expensive resource that can't just be sent for anything. It has to be sent for the right patient, and it has to benefit the patient in such a way that the outcome is actually changed for that patient. And if that's not the case, then flying the patient is probably not the right decision. And it seems like a really strange thing for a HIMSS company to be saying, but when we use the resource inappropriately, first of all, we put other patients who may benefit from that resource use at risk. And we also put the sort of perception of HIMSS at risk, where flying patients who shouldn't be flown or where there's not going to be a time benefit really makes the whole system just look really silly. So what we've come up with, and this is based on a whole lot of conversations with many of the other private service providers, but also many of the available resources within the government space, as well as some of the funders, is that HIMSS should be deployed when it offers a real advantage. And the advantage doesn't necessarily always need to be time, but time is a significant factor when it comes to activating HIMSS. If we're not going to make a time advantage, then there has to be really clear, and the other benefits then need to be quite strong. They can't just be sort of weak reasons for activation. So time advantage is really important. And when we say significant time advantage, 4 minutes is not a significant time advantage. Whereas something like an hour or an hour and a half may be a really significant time advantage. And in some situations, I guess shorter times may be a high advantage. The system has to deliver skills to the patient that are not available on the ground, or equipment that's not available on the ground. So if there's a provider who can do what the HIMSS team can do on the ground already and there's no time advantage, there's almost no good reason why a helicopter should be dispatched for that patient. Sometimes there is an expert advantage, and it depends on, I guess, on the crews that are on that machine. But sometimes the HIMSS systems do have access to ECPs and the ability to bring RSI to a patient, but often also doctors. So we may or may not have a doctor on shift, and doctors with specialist skills may be more useful. So sometimes picking up a trauma surgeon and taking them to the patient may be the most appropriate set of steps for that patient. And often that can't be done with a road crew. And that also goes with sort of specialist equipment. And then thinking about things like access, like terrain, road conditions, infrastructure barriers, roadworks, What does that road surface look like? Is also really important. And in places like our rural South African spaces, where you may have a relatively good road surface, but 3 hours in the middle of the night exposes the patient and the crew to quite dangerous situations like wildlife and that kind of thing. That might be the reason for activation. Cover, so making sure that the local area, especially in the rural spaces, is still going to have cover by a specialist service, especially for sort of the primary cases. So this is a bit of a difficult one, and definitely not one that the medical aids seem to understand. But taking the only ALS out of a 400-kilometer radius for a 8-hour transfer to move a single patient puts that entire area at risk of not having the kind of support that's required. So that sometimes is a good reason for why HEMS might be sent. And then lastly, just in terms of transport stress, and this is a bit of a tricky one because HEMS on its own creates a little bit of transport stress, but it does so for a much shorter duration than sometimes your road stress with a patient. So you may have a 4 or 5 hour road transfer time where you'll have 5 hours of exposure to stress, or you could have an hour and a half of flying time. Although the stress is maybe 20% higher than what's going to happen to the patient on the road, that they are going to be exposed to stress for a shorter period of time. And so obviously, depending on the condition, you might make a decision for the patient based on what makes sense. So it is really tough, but these are sort of the things that we're thinking about when it comes to, is this an appropriate patient to send a helicopter to? We're also using just this three sort of process filter. So the first is the clinical criteria. So we're not going to even have conversations about logistics if the patient doesn't meet the clinical criteria. And we'll chat about what that looks like in a second. But we also have a quick look at the contextual feasibility. Is this a patient who really does have any kind of advantage when we move them by air? And then lastly, logistically, can we actually provide the kind of care that this patient requires? So logistically, is it going to be a time benefit? Is there a service on the roadside or near to the patient who can do what we can do? Is there going to be logistically a support for this patient? And if the answer is yes, then and it meets all of the other criteria, then we think about activating. Under logistics also goes things like weather and fuel and those kinds of things, landing zones, just because if we're not going to really have an advantage in terms of time, then sort of things like landing at a facility versus having to land at an airport and drive to the patient are going to make big differences in the big sort of the total picture for that patient. So we'll have a look at some of the other stuff in a second, but I guess I want to pause at this point and I just want to ask sort of the bigger team, what are some of the things that you think a patient should be flown for? And maybe we could get some of the teams from the road, things from the the sort of hospital spaces where people are unsure or would be interested to know if we're going to fly. So I see some people typing, but if there's anyone who wants to speak, that's also really a good idea. If anyone's keen to chat. Okay, so we've got one example of prolonged entrapment. Shahid, your hand's up.
Hi, morning. Yeah, it's I think the most important ones are the ones where you want to limit time out of hospital. Take that in relation to mission time and then time to definitive care. But then in that space as well, how long does it take to activate as to moving by ambulance? So all those things need to be taken into account. If you look at sometimes some of the flights, maybe from the West Coast into Cape Town by helicopter, could take a mission time of about 2.5 to 3 hours because you've got about 45 minutes flying time to there, then loading and flying back. So all those things need to be taken into account. But the advantage, and obviously, of using the heli is a point-to-point system.
Cool. I think that's a really good point. And you've actually kind of hit some of the things that I want to cover. I want to see maybe if there's some other ideas. So we've had a few things like spinal injuries, maybe depending on road condition. We have difficult access, so like mountains, distance to facility in rural areas, polytrauma in faraway places, diving incidents to oxygen chamber, time sensitive, so like spinal cord injury, lysis, those kinds of patients. Availability of ground units, time to definitive care, specialists only available at a further away facility, so things like the trauma specialist. There's a few more people typing, so I'm just going to see if there's any other people who have any other ideas. Maybe if there's anyone who wants to add their 2 cents verbally. Lucas, go ahead.
Hi, Caleb. Hope you're well. Yeah, so I think the one that's quite important is not necessarily time to the nearest facility, because that is often what happens on the road, but especially in rural contexts, it's also time to the most appropriate facility. And that's often, I think, where HIMSS can provide a really good benefit to actually getting the right definitive care instead of going to the small hospital and then having to be transferred later.
Okay, that's a really reasonable reason as well. So getting a patient to a facility that's the right facility from the first point of contact rather than having to wait in between. I see there's also high risk obstetric emergencies, limited ALS in the referral or the rural setting, and then time constraints for CVA patients. I think all really reasonable options. I see Isaac's been typing for days. Okay, there we go. If the facilities in your area are not capable, and you can weigh up the option of driving or waiting 40 minutes and then fly the patient to definitive care, sometimes a transfer delay can increase mortality for patients. So I think if I look at the comments and listen to some of the comments that we've had, I think we have moved a little bit away from the traditional HIMSS criteria, which are really badly sort of not really badly thought out, but I think is what we had at the time. So it was things like a head injury with a GCS of 5 to 12. It was things like a spinal injury. It was anaphylaxis unresponsive to treatment. It was hypotensive or hypovolemic. And it was super clinical things that may or may not be indications, but are not necessarily good rules for when a patient should be moved. And so what we've kind of done in our space is we've moved a little bit away from the absolute clinical criteria, and we've moved more towards, so instead of saying a condition should be flown, we've said that these are the three criteria that we're looking for. Because it doesn't really matter what the condition is. If it meets these three criteria, then we've got a good reason to fly the patient, provided that the flight actually meets the benefit. So if the flight doesn't decrease the time or decrease the risk or decrease the mortality, then there really isn't a good reason to be flying that patient. So in this first gate, this is kind of what we use as our criteria. So the severity of the patient's condition requires an urgent high-level response. The patient is really sick. So they have to be a patient who is injured or ill in such a way that they really do need a high level of care. The second thing is that the illness or injury must be progressive. The condition must be getting worse, and time is a critical factor to prevent deterioration. So for us, it's going to be things that are time sensitive, need to be moved rapidly. And that's not just time sensitivity for mortality, but also time sensitivity for morbidity. Because the earlier we can get a patient to the right level of care, the better that patient can do, the less of a burden that patient becomes on society, less of a burden that patient becomes on the rest of the system around them, and just the better outcome for the patient. So he can go back to his family and he can really be part of society. And then the last one is the consequence, so that without immediate advanced intervention, the potential outcome is a loss of limb, a loss of life, or severe organ damage. And this really aligns with the sort of definition of emergencies in the South African literature. It has to be of high acuity, it must be progressive, and it must have a consequence. If the patient who is trying to be flown doesn't meet any of these criteria or all three of these criteria, then we really are not activating for the right reasons, if that sort of makes sense. So you could kind of put any clinical condition into this picture. So let's take the old criteria and have a look at the spinal injury patient. So the spinal injury patient who has had a loss of the ability to ventilate themselves is a high acuity patient. The severity of the patient's condition requires an urgent high-level response. It may be progressive, and in the pre-hospital space, it's really difficult for us to figure that out, but we're going to make the benefit of the doubt the decision. And so we're going to assume that it is relatively progressive, and that if something can be done about it, we may be able to potentially fix it or reverse it, depending on what's wrong with the patient. And then obviously that kind of patient does have high level of consequence. Without immediate advanced intervention, the potential for this patient is life damaging. But if we take that same patient from not in a pre-hospital space, and we put them into an in-hospital space, and they're in a facility where they have access to somebody who can ventilate them, they have access to some kind of imaging, and we can figure out what's going on. And we realize that maybe that patient sees spinal cord is completely transected. It really takes the progressiveness out of that patient condition. So yes, the patient is high acuity, and yes, the consequence is high, but moving that patient is not going to change their outcome, unless moving that patient changes the outcome because the facility they're in can't ventilate them, can't manage the airway, can't BVM ventilate until help arrives. And so as much as it's black and white, it's actually, these decisions are just super gray. And getting everyone on the same page is part of the challenge. Some of the other physiological sort of triggers that we use, again, it's not about the diagnosis of the patient as much as it is about the physiology of the patient. So there are some clinical factors that really do meet the criteria, but they're not good on their own. So they don't really meet the criteria by themselves. So things like a decreased GCS. Yes, a decreased GCS is an indicator that we're in trouble, but is it decreased because the sugar is low, in which case flying the patient is a total waste of time? Or is it decreased because there is an expanding hematoma in the brain and the progressiveness is now part of the big picture? A low blood pressure on its own is not HEMS criteria, but a low blood pressure plus multi-system trauma definitely means that there is a acuity, progressiveness, and consequence to that injury. And then some of the things like a respiratory rate less than 10 and a respiratory rate more than 29, those are all patients who may meet the criteria, but we have to look a little bit more deeply. And then if we look at some of the traditional criteria, we speak about things like multi-system trauma, neurological trauma, unstable chest wall, pneumothoraces, the STEMI patient, the stroke patient, paralysis or deficit, and then the obstetric neonate or pediatric patient, because often we're bringing skills and equipment that are not available in the pre-hospital space to that patient, or in the clinic or in hospital spaces, in rural spaces. So that's going to be our clinical sort of decisions. Filter 2 is going to be talking about, can we actually do the mission? So is this something that is feasible in our environment? So yes, the patient is ill or injured, and we need to do something to try and help that patient. But now we've got to go and look at, what does the world look like right now? Contextually, can we actually fly? So are the weather conditions relatively safe? Do we have a landing zone? Can we actually safely land and not put the whole team at risk? Have we got an accepting facility who are going to take the patient? Have we got a crew and aircraft that's ready? And hopefully that's always a yes, because it's a 24-hour operation. So you should always have crew and aircraft that's ready. But it does take into account things like crew duty time, especially for the pilots, and obviously aircraft maintenance status. So if there's something wrong with the aircraft, flying is not a good idea. And then time of the day, depending on what kind of patient you're dealing with. So like the rescue environment becomes a little tricky in the dark. And so there would be some cutoffs and some safeties around sort of night times. And then the last one is probably the most difficult one to apply in real life. And this is, do we actually offer a logistical advantage if we fly this patient? And this is the one where we find ourselves standing down from cases a little bit more often than I think any flight crew on the planet would like to stand down. But if a ground crew can do the same or better, and they can do it in the same time or faster, there's no reason to send a helicopter crew. And so this is where it gets a bit tricky and where there's definitely a little bit of resistance and some discomfort around the relationship between a HEMS flight desk and a ground crew. So sometimes ground is just faster. And some of the data we have is that within around a 70-kilometer radius, ground is usually faster, but it depends on what's happening on the ground, right? So we had an example a little bit earlier of prolonged entrapment. So a patient who is currently entrapped and who is only expected to be released in about the same amount of time as it might take for a helicopter to get to them, that's a pretty clear time benefit, because as soon as that patient is released, they're going to be moved into a helicopter, and then time to care is a whole lot shorter. But if the patient was entrapped for a long period of time and is now out, and that's when the call comes in, if it's more than 70 kilometers, there may still be a time benefit. But if it's less than 70 kilometers, it's honestly faster for a road crew to throw that patient into the back of an ambulance and drive to a facility. Because a startup time on most of the activations for our helicopters, and this is I can only really speak from a rocket perspective, but I'm fairly sure that the startup times and the activation times are pretty similar across the board. From the moment the phone call is made, you're looking at about 15 minutes, depending on how long the authorization processes take with the different companies. So if you've got a 15-minute startup period, within 15 minutes, your road crew will already have moved 15 to 20 kilometers. And then that last 50 kilometers is like 30 minutes. So to wait on scene with a really sick patient for the next 30 minutes to be at hospital at exactly the same time as you would be at hospital with a helicopter doesn't make the cost of that resource worth anything. When we're talking about more than 70 kilometers, suddenly the benefit starts to increase. See, there's a hand up. Momaneng. Hand has gone down again. Okay, then if the receiving facility is less than 30 minutes away, there probably isn't a time advantage. If there's a skill match on scene, so if the person coming in the helicopter is the same as the person on the ground, then there is almost no benefit unless there's a time advantage and unless there's an equipment advantage. And this is where it gets a little tricky. So often if you've got an ILS team on scene, and they are 60 or 70 kilometers away from care, then it does make sense to potentially send HEMS, because you're bringing a skill or a resource that isn't maybe available to the team on the ground. And then lastly, are there terrain barriers? And the terrain barriers are a little tricky as well, because especially if we're dealing with a medical aid patient, a terrain barrier is seen as a rescue unless the patient clinically meets the criteria. They're not seen as a medical transport. So if it's like an isolated femur fracture, but the patient is difficult to access, that's a rescue. That's not a sick high acuity patient. And so they won't cover the cost of that flight. So it gets a little tricky. I see there's a question from Ivor, and are we talking about 70 kilometers as the AMBO drives or 70 as the heli flies? So we're talking about if the ambulance is 70 kilometers or less away from a receiving facility, the helicopter doesn't make sense. So that would be driving the 70 kilometers. Obviously, if it's 70 kilometers of dirt road, we're talking about a different story. So it is a little bit adaptable, but we're kind of using 70 kilometers as our sort of baseline to say no. And then if there are really good mitigating circumstances, then we'll have that conversation less than 70 kilometers. So basically, we use this checklist to think about how are we going to activate for a patient. So is the patient ill? Do we offer a skill, time, or access benefit? If the patient is still entrapped and still in the vehicle and presenting with clinical signs that we've got a really sick patient, then probably yes. Will a delay lead to worsening outcomes? Does the ground or hospital team have limitations that can't be overcome? And have we looked at the road options that make sense? And if there aren't any, then probably yes. If the closest facility is not available and appropriate, then probably more a yes. Does the patient meet clinical criteria? Have we followed the referral pathway? And this becomes really important when we start talking about things like our kids flight program, where we move patients who are not private patients, but the referral pathway of the state system still has to be followed. Otherwise, we don't actually benefit the patient. One of the last three checks we just look at is the weight compatible? So weight becomes really tricky because patients over about 170 kilograms start to really put strain on the helicopter, first of all, but also on the mechanisms for loading and the crew for loading. And then obviously patients who are very broad and don't fit into the machine may be part of the problem, although depending on your machine configuration, this can be overcome. Are the weather and fuel checks complete? And then is this in line with our clinical values? If we're not benefiting the patient, we should not be doing the flight. Lucas?
Hello, I'm not sure if I missed it. I just want to clarify, where did you guys get 70 kilometers from specifically? Just because, well, the reason I ask, the only evidence kind of at the moment in South Africa to back this is that Stussen paper, the geospatial one, and that cutoff he did on the simulation study was 119 kilometers was where they found time benefits. So yeah, I was just curious how you guys got to 70.
So there are two studies. We use the Stussen study specifically for the acuity and sort of time benefit stuff. But there's a second study, and I think it was a South African study. I must just go and relook at it again, that looked at somewhere from anywhere around 70 kilometers. So we've, as obviously as a commercial company, the 119 kilometers is almost unattainable in pretty much every environment. And what we have sort of seen, and it's not really well data backed, other than the single study that is available that says 70 kilometers may be the place, is that when we activate in distances of less than 70 kilometers, we often spend just as much time as the road crew would spend. So it's sort of a little bit based on our data and then based on the Stussen study and then the second study, which I will find for you and send on the group.
Thank you. I'd appreciate it.
The problem is that we don't really have great data in South Africa. We have relatively good UK data, we have some good US data, and there's some really interesting data from like New Zealand and Australia, but there they're talking about 70 kilometers over water, so it becomes a little bit tricky. But in terms of South African data, we are notoriously bad, first of all, at collecting data. And then because all of the HEM services that are really collecting that kind of data are mostly private or have some kind of financial challenge or affiliations, publishing that data is really difficult to get access to. So yeah, you're right. What data do we have and how do we make these decisions? At the moment, it's mostly a thumb suck and then see what works or doesn't work. We've also kind of split the sort of decision making from a primary scene call to an IHT. And so from a primary scene call, we can receive that call from any provider on scene. The authorization is usually a little bit expedited in terms of the paying patient, so the private patient or medical aid patient, because a lot of the companies are quite open to the fact that a primary may need a much quicker activation sort of procedure. And there we're looking specifically at things that are time critical and where you're going to make a difference in terms of access to the right care. When we talk about IFTs, we're talking about the treating facility or the treating healthcare provider needs to make the call because they are the person in charge of the patient, and superstition is unacceptable. There it gets a little bit tricky because the funders often want to be able to review and authorize these cases. And so often when there's a delay, the delay is really happening in that authorization phase. And that is unfortunately beyond the ability of many of the HEM services to be able to manage. Because the vast majority of the funders are not managed by the HEM services, it gets really tricky. But there we're looking at the need for specialized care, expertise, or resources not available in the referring facility space or sort of in the geographic location. So what I also wanted to just quickly cover is, especially for the guys who feel frustrated when they phone and then get a no to HEMS. Firstly, there are 5 big reasons why specifically Rocket won't activate. So number 1, road transport is quicker than the total response time and activation time and flying time and time to the patient and time to hospital. So it really depends on what the patient needs. If the patient is on a scene and needs airway management, then we would look at time to HEMS arrival if there's no ability to provide airway management on scene. Having said that, airway management is also not usually a life-saving intervention, so it may be something that you may need to do at a facility. If the patient doesn't need an intervention that is critical at the point of contact, but needs a facility that is appropriate, then we have to take into account the total flying time versus the ground time. So we can't be taking longer to fly a patient when the benefit is time. It just doesn't make sense. If the patient is super stable and doesn't show any signs of instability, there's no good reason to fly the patient. So as much as an entrapped patient is a high mechanism, an entrapped patient could have nothing wrong with them. And so when you get them out, you suddenly realize there's no injuries. Flying that patient is a total waste of time. If obviously there are some safety constraints, so weather is dodgy, landing zones are not safe, or crew and duty mission times are unsafe, that's very unlikely in most of the HIMSS environments in South Africa, that last one, then we will not fly. If there's no time critical advantage, and specifically if the patient's condition is outside of the window period, it doesn't make sense to fly the patient. So for things like a stroke, if the patient is already at 4.5 hours beyond the stroke time, or beyond the time last seen normal, there is no benefit in flying that patient. Unless they're going directly for thrombectomy after a diagnostic procedure. So it can get a little bit tricky. And then if there's already the skills on scene, depending on how far you're going to need to move that patient, it doesn't really make sense to send HEMS if you've already got the resources on scene to provide the care that the patient requires. So these are the big 5 for why you may not get a yes on your HEMS activation. So what I wanted to do is just run through some examples. So this is a patient 40 kilometers from the nearest trauma center on a highway, multiple rollovers. This patient was extricated already, vitals are relatively stable, and the crew on scene are requesting HEMS. Any thoughts? Super quiet.
Hi, Caleb.
Hi, go for it.
Sorry, man. Also depend, it's very short distance, but the time of day and the traffic congestion will play a big role into the transportation, which is quicker and which is faster,
Okay, super relevant, but let's run through the 3 sort of filters. Karine?
Hi, yes, I was going to agree because the mode of injury is quite high impact, and then it is the distance is a little bit. I mean, it's a shorter distance, but it's I would imagine it's a good idea to fly this guy with the mode of injury.
So let's maybe go back to just our 3 filters. So number 1, the clinical criteria. Is the patient a high acuity, progressiveness is proven, and high consequence patient? So we've got relatively stable vital signs. I guess we don't have a whole lot of data around injuries, and that would be information that we probably need. But just looking at the data they've given us, do you think that we're going to clinically meet the criteria? We don't really have enough data, but probably not. You'll be surprised how often this is the data that is sent through with a HEMS request, which means making good decisions is probably not super good or super easy. Our second sort of decision is going to be, is it feasible contextually? So let's just make sure that there's somewhere safe to land, that the weather is safe, and that there's an accepting facility. That probably makes sense. And then the last one is, do we offer a logistical advantage? So at 40 kilometers, depending on the traffic, I guess. So if you're sitting sort of behind a massive accident that's going to take you 40 minutes to get to the hospital, that's a big problem. But if you're sitting 8 minutes from a facility, or 40 minutes from a facility, then probably ground is faster. I mean, you'll probably already be 15 minutes to the hospital by the time the helicopter even expects to get activated, to get in the sky. So that's a little bit of a challenge. So what I said over here is in terms of my decisions, and I forgot to make this thing disappear, so that's really annoying. But no, this doesn't meet criteria because, first of all, we don't have enough data. Second of all, we've probably left it a little bit late. We're probably looking at about a 40-minute drive time. And if the patient's already extricated, there really isn't going to be a benefit in terms of HEMS. Does that kind of make sense? And you can see why emotionally you want to just say, yeah, send the helicopter. But when you're talking about the difference between a 4,000 Rand transfer and a 70,000 Rand transfer, suddenly, if you're the person paying, it becomes a little bit challenging for a super stable patient who didn't need any additional assistance. Okay, so that's probably a no. Case number 2, asthma in a rural area, so 80 kilometers in the Northern Cape. A 25-year-old severe asthma patient, respiratory rate of 40, speaking in one-word sentences, ILS is with the patient, blood pressure is 90/50, heart rate 130, and SATs 89. What do you guys think?
Can I take a stab at it?
Sorry, I'm talking to myself here. Shahid, go ahead.
Okay, so you say 80 kilometers, ILS is on scene, 80 kilometers to the closest hospital. Okay, so we're looking at Northern Cape rural. You could probably get to hospital in less than an hour. How much treatment has been given? Can the ambulance move with the patient in the meantime? Is the heli out of the hangar? Is it in the hangar? What's your flying time to the scene? Is the appropriate place to land? I think all those factors need to be taken into account. Then you're looking at what's the size of your helicopter? What's your space inside? Is this patient going to need advanced airway management somewhere along the line? So those are all the factors that you need to take into account. Yeah.
Cool. So those are all really reasonable, right? And I think this one is probably a little bit easier to make a good decision. Are there any counter decisions to or counter thoughts to that? I see there are some hands up. Sandile?
Morning, everyone. I don't have any counter thoughts. The question is if you compare HAMS to ground transport, will the patient make it to hospital on ground transport faster than the response of HAMS? That's one of the questions that one needs to ask. Yes, the skill set might be limited on scene. However, if the response from HAMS will take longer compared to the patient being moved quickly from where they are to an area of definitive care. If, for example, then the hospital is maybe in Kimberley while one is in Kathu, then for sure you really need HAMS there because it's a long way.
Cool, Sean.
Caleb, it's Debs.
Go ahead.
Hi, I want to bring in a bit of a counter thought, and I want to bring in the patient's reality that he's living in a rural area. He's got exacerbating asthma, and you now want to put him in a helicopter. So stress exacerbating the situation, because the patient's reality might not be, the stress of putting him in a helicopter. He might not know or want to be airborne, and that condition may progress quite rapidly. So just a different thought of bringing in a patient's reality there. He might not have ever seen a helicopter close by, only knows the ambulances in his area, especially if it's a rural area.
Yeah, really reasonable thoughts. I do see that the vast majority of people have said yes, probably would fly, unless you've got ALS really close by. So that's a really good question, right? We've got to figure out what resources do we have nearby to this patient so that we could give them the best possible care. Because this patient could turn around with some MagSelf, but it would be difficult to get the MagSelf into the patient appropriately without an ALS provider nearby. So I kind of went with the decision here. Probably a yes. So why yes? Although this patient is currently protecting the airway, there is a severe asthma, unresponsive to the medications that they're giving the patient potentially. ALS not available because the ALS is almost as far away as the hospital is. So however long it's going to take to get to the hospital is how long ALS is going to come. Road conditions may be part of this big picture. And so this for me would meet all three of the criteria. So one, clinically, the patient is in a severe asthma attack and requires medications that are not available by ILS, with ILS on the road. It's going to take 30 minutes to get to the patient, but what could be done is a meet en route. So the ILS could drive to a point a little closer and try and minimize that time with enough time to set up a safe LZ. Does it meet the progressiveness? So it meets acuity, yes. It meets progressiveness, yes. It's a patient who's getting worse and who may need advanced intervention. And then is there a high risk of mortality or morbidity? Yes, there is a high risk of mortality or morbidity for this patient. Logistically, can we do the case? Probably a yes, and we wouldn't be having the conversation if the weather was terrible. Then it's really easy. And then lastly, is there a time benefit? And there probably is a time benefit because an 80-minute drive an 80-kilometer drive to hospital in a rural space is probably around a 90 to 100-minute drive, whereas we could be with the patient with an ALS resource within 30 minutes. So for me, this would kind of be a decision around what is right for the patient. They're going to need help. They're going to need to get really good care really quickly. So we probably want to have ALS to them as soon as possible. But you can see how gray it is to make good decisions for patients with a very expensive resource. We're going to go to case number 3. So case number 3 is a 6-year-old febrile seizure in a clinic, was seizing for 6 minutes, now post-ictal with no medications given. Vitals are stable, and let's say about a 60-minute drive to the closest facility. Thoughts? Was someone saying temperature control and just road transport? Go by road. Patient could seize again. Sandile?
Well, if the patient has stopped seizing and the vitals are stable, the question would be now, are there reversible causes searched and found? Are the clinicians on scene capable of managing the patient should they seize again? That would now speak to skill set, and that will probably influence a decision whether or not you should on HAMS. The distance from scene to definitive care would also play a role.
Cool. Caspar?
Hi, good morning, everyone. Yes, I want to know if you're talking about a clinic, is this still in a rural area where you have a mobile clinic, or is it a clinic in a small town? And yeah, I would rather, if it's a 60-minute drive, rather activate HEMS, because if I don't have an ALS close by that can drive that 60 minutes with me, then yes, I will rather call HEMS then.
So you can see, I think, from some of the comments and some of the mixed ideas here that the answer is not always really easy. So let's run through the three sort of filters. So number 1, clinically, is this patient really sick? Are they really sick? And I think probably the answer is no. I mean, a febrile convulsion is not necessarily life-threatening, right? I see there's some hands up, so let's just maybe go Sandile again and then Pierre.
I know, I think my phone is doing its own things here. Sorry about that.
No worries. Pierre? I'm not sure if Pierre is able to unmute. If you get it right, you can chat. Okay, so clinically, is it a super high acuity patient? Not really. A seizure is scary, but it's not going to kill the patient. And if you can control the fever, which is something that a mom can do, then probably won't have a seizure again, right? Number two, is it progressive? So is this patient going to get significantly worse if we don't have care there? And then also, what does that care look like? So I think some of the questions around what does that clinic look like might be reasonable. Pretty much every clinic in the country has Empaped. So an Empaped suppository and a drop in that fever is going to at least put the risk of seizing lower. Thirdly, is this patient at high risk of morbidity or mortality if we don't get the patient to where they need to go really fast? And again, probably not. There's been a few comments here. Seizures are usually relatively self-limiting, so probably not a massive challenge. If we have a look logistically, are we gonna be able to do it? That's probably a good question to ask. And then thirdly, do we have a time benefit? And yes, we may have a time benefit, but we've already said that the condition is probably not progressive, and the treatment can be done by almost anyone on the road. Even a BAA is able to manage fever at least partially or think about the next step. So from my perspective, this would be a no. It's not status epilepticus. The patient's not unstable, and a PEDS case doesn't mean fly. A PEDS case is a more likely activation, but where you've got a patient who isn't meeting the criteria, there is no reason to fly this patient. And I can almost guarantee that there's not a medical aid on the planet who would pay for this case, which means you could fly, but you're going to be doing it for free, which is a 80,000 Rand community service every time you do it. Any thoughts? Okay, so there are some comments which are really valuable. So what is the ETA of the ground crew? That is a really important thing, right? So if the ground crew is going to be 4 hours to get to the patient, then you are going to probably think about activating for that patient, depending on resource. But what might be a better thing to do is to have a chat with the sending facility and give them some clinical advice. Start some Empaped. Let's get the patient cooled. Let's take off all the extra clothes. Let's maybe start an antibiotic, and let's think about what is reasonable for the patient in front of you. And so flying the patient isn't the answer just because you feel anxious about the patient, right? Oftentimes, it's great to have the phone call because you'll get really good support, but the answer may not be to move the patient by air. The answer may be, let's help you figure out what's going on with the kid in that environment. And there's some really nice reflections here. We do tend to think about HEMS when there's a child involved. We do, and we probably should for the right child. For a child where there's going to be a benefit in terms of time and progressiveness and getting the patient to the appropriate facility. So Ben has just mentioned change one thing. What if the child is not febrile but has status that's not resolving? That's a completely different story, right? So the patient who's in status epilepticus, super high acuity, super high risk, morbidity and mortality goes up significantly, and progressiveness, the patient is only going to get worse over time and not better. Patients in status, that's a good activation. Does that kind of make sense? See, there's another hand up. Gary? Gary? Okay, I don't know why people are struggling with the unmute. Let's go on to the next one. Okay, so this one is a bit of a series. So we've got a suspected stroke 20 minutes from a CT scanner, positive fast, onset 2 hours ago, and the team at the facility are asking for HIMS. The facility is quite a basic facility. They don't have a CT scan, and they want to move this patient as quickly as possible. Super quick, yes or no? Yes, we've got a few no's, we've got a few yeses. Okay, so this patient, depending on who is available and if there's a resource available to move the patient at the facility, probably a no. So if there is someone there available to move the patient, no makes sense, because 20 kilometers drive is going to be 15, 20 minutes. Get that patient in the ambulance and move. Even if it's an ILS crew, get going. Even if it's a BLS crew, get going. In fact, if I was at that clinic with my car, I would put the patient in the car and we would move, because that's what's the right thing for the patient. We can talk about the legalities later, but the patient needs to get to a facility with a CT scanner, and we're running out of time. Let's change it up just a little bit. Suspected stroke, 150 kilometers from a CT scan. Onset was an hour ago, and the local facility are looking for help. Do we fly, yes or no? Okay, so now we've got a whole lot more yeses. And this definitely makes sense, right? We don't have a big window, and I should not say no, it should say yes. We don't have a big window of time with the stroke. We have a patient who has a 3-hour window. We've got a patient who is in big trouble. It starts to get a little bit tricky when we're talking about onset times. So in this case, 150 kilometers is going to take about 40 minutes to drive. So to get a team to the local facility, we're then already, sorry, not 40 kilometers to drive, 40 minutes to fly, and about an hour and a half to 2 hours to drive, depending on your ability and your speed. But we're already out of the window period if we're going to drive. So ground is going to be way out of the safety limit, and it's going to be lost in the drive. But if we fly this patient, 40 minutes to the patient, even with a 15-minute activation, puts us at about 55 minutes. And then 40 minutes to the facility puts us at about 90 to 100 minutes. With an hour of onset, we still have some time in that window period to treat the patient. To change it up a little bit and say that the only thing that's changed now is that the patient had an onset time 3 hours ago. Do we fly? Okay, so immediately we can see that if the patient just has a positive fast and a 3-hour onset, flying is pointless. If we change it up even a little bit more and said, okay, 3 hours onset, but the patient's level of consciousness is dropping and the clinic is not capable of managing that patient, then suddenly the answer is potentially a yes, because now you've got that high acuity patient. The progressiveness is not necessarily a big problem, but the risk to mortality and morbidity suddenly goes up. So you can see with the same clinical picture, a suspected stroke with a positive fast, there is so much data that has to be given to the team to be able to make a really good decision about flight. So this would probably be a yes. And so I guess what I wanted to kind of summarize then is that we have to rely on the HIMSS teams, and especially the decision-making teams, to make the best possible decision with the data that is available. And the problem is that often the data that is given is not enough to make a really good decision. We have to expect that the HIMSS teams and flight desks are going to be transparent with the decisions. So give as much information about why a decision was made or not to the team who are asking for the flight. We have to be able to justify why we did or not. We have to be open to scrutiny and review. So when we make errors, we have to be able to look at them and we have to be able to chat about them and figure out how we do better next time. And we have to make sure that the person at the center of that decision is not the practitioner, but is the patient. So if the thing we're going to do is going to change the patient's outcome and is going to give them a better chance of surviving with good neurological outcome, then that needs to be a yes. If we're going to use this expensive resource and we're going to use it for the benefit of the patient, it actually has to benefit the patient. So I guess what I want to ask everyone who's sort of in the road space, and then also everyone who ever organizes a HIMSS transfer for an IHT, is think about giving the decision makers the most information that you have available. And if you can sort of put that information together like this, give the team the clinical criteria, give them the reasons for why driving that patient isn't worthwhile and isn't going to work, why the time is too long, why the access to a helicopter is not available, why the access to an ambulance is not available, why the clinic you're in or the hospital you're in can't manage that patient. And then lastly, have a look if there is not a better option in terms of time. If you are 10 minutes to a local facility who can at least start some blood for the patient, it may not make sense to fly the patient from the scene because you're going to wait 15 or 20 minutes to get the patient off the scene when you could start treatment for a patient in a local facility. If the local facility is going to do no more than what you're going to do, then flying the patient definitely makes sense. And so presenting the data in this is the information I have clinically, this is the information I have about the context of the patient that I'm with, and this is why I think there's a benefit. It's way easier to give a yes or a no answer in that 2-minute decision period. I don't know if there's any questions or any comments from anyone on the chat. See, there's a hand up. I'm just going to mute people who are talking. Jacques.
Can you hear me?
Yes.
Yes. Thank you. Can I quickly go back to that very first scenario, the 40 kilometers rollover incident? Like you said, if the skill set is on scene that you have, then my answer would also be no. Maybe an ILS crew with that information you have, I would also probably say no. But if you had that little bit of extra information, say for instance, like the skill set is not on scene, but you had a little bit of extra information saying like there's pain or bruising over either the chest, the abdomen, or the pelvis. You know, sometimes those patients present clinically stable, but they tend to hold up like kids until they hold up fine until it suddenly horribly goes south. Would you rather have your skill set on the way and go and pick up the patient, or risk that through have it happening to them en route and then getting stuck in traffic into the city center?
It's such a tough question, right? Because what is the skill set that that patient then needs? Jacques?
Yes.
What skill set does that multi-system bleeding trauma patient require? They need a surgeon, right?
That's if I say if they don't have that skill set on scene that you have, and they're going to transfer that patient with that little bit of extra information. I mean, if you look at advanced resuscitation, I don't know if you carry blood products.
So it does get tricky, you're right.
You see where I'm going?
It depends on the distance, right? But like 40 kilometers, even with the BLS crew, is going to be at the hospital way quicker than a helicopter is going to be at the hospital with that patient.
Okay.
And the skill set that patient requires is theater. Doesn't need a tube. The patient may need blood, but unfortunately, most of the helicopters are not carrying blood. They may need TXA, but hopefully that's coming into ILS scope relatively quickly. But what the patient really needs is someone who can cut them open and save their life. And so it gets really tricky. You can see immediately why it's not a black and white answer.
Thank you.
Tough. Casper.
Hi there. The thing is, I want to go a little bit more back. You talked something about the femur fracture that doesn't need to be flown because it becomes a rescue. What is the difference between that patient and a patient that is rescued from a vehicle? Because I don't understand it. If I need pain management because I'm an ILS, I don't have an ALS with me, and I know a heli will be the perfect thing to have with me to give that extra pain management. how do they classify that the difference between a motor vehicle rescue and a rescue on that patient
So
that's got a femur fracture?
So this is a sort of a specific to the medical aid thing. The medical aids won't authorize a flight or pay for a flight if the patient doesn't meet the clinical criteria as well as whatever other criteria is required. So if you've got a patient with an isolated femur fracture, totally stable vitals, but they're in pain, the chance that that flight will be paid for is as close to zero as you can get because the patient doesn't need to be flown. And so it's really tough. We have flown those patients and we write those bills off. Those are free community service flights because there are no medical aids that are willing to pay for a non-high acuity patient who only needs to be removed because of the circumstance of the environment. A flight for a patient from like a car wreck, if you've got the clinical criteria, query injury to the chest, abdo-pelvis, vital signs that match that, and then you move the patient, then it's clinically qualified first. A just access to the patient isn't a good enough reason, and is it right? No, it's not right. But the medical aids don't cover removal from a difficult to reach environment. They only cover difficult to reach environment plus the clinical criteria to actually fly. I don't know if that makes sense.
Okay, yeah, it does. And if the patient does have say, a suspected spinal injury, will they accept that?
So there must be clinical clues and not just mechanism as the reason for the flight.
Okay.
So they must have neurofallout. They must have some kind of focal neurology to show that there is a potential spinal injury.
Okay, great. Thank you very much. Appreciate.
Cool. And I think we've kind of hit on something that's really important here in that in South Africa, especially in the sort of flying situations, we are not always making the right decision for the patient. We are making the decision that is going to be covered because it's such an expensive resource. And that gets really difficult. If we had a system where patients got access to the care they needed based on the acuity of their injury, we wouldn't have to have these conversations. If we had a government system that flew the right patients at the right time, okay, we'd have some other conversations because the helicopter would be busy quite a lot, but it would be a whole lot easier to make good decisions for the patient in front of you. Any last thoughts, questions, ideas? So I see there is a question there, and it's quite a complex question, but I think the answer to the question is, if there is a time benefit to HIMSS and the patient meets the criteria of high acuity, progressive in nature, threat to life or limb, then the answer is a yes, let's fly the patient. If it doesn't meet those criteria and it's not going to add a time benefit, then there's no point in flying the patient. So what is the cost of HIMSS activation? It's different for different machines, but your average cost for an hour of flying is somewhere around the 45 to 60,000 Rand an hour range. And then just max range of the helicopter in ground kilometers. Again, it depends on the machine that you're using. Also depends on the weather conditions. Also depends on wind and that kind of stuff. But average around 450 Ks in a single tank. So obviously you need to be able to think about getting there and back. So if there's no fuel there, then probably around 200 kilometers. But it depends on a lot of different things. Casper, go ahead.
All right, I've got a question, and I'm speaking, and I'm going to ask this question because of a circumstance that I know of. I know you've got a heli at Kimberley. For instance, I'm taking this as a scenario. My brother-in-law has got a cardiac problem, and suddenly he's got chest pain and so on. And we phone an ambulance, and the ambulance say it's about an hour away. what would be the best? The question I want to know, what would be the best to activate immediately if I ask for an ambulance and they're more than an hour away, or is Rocket, the heli is about 42 kilometers away from there. So what would be the best for me to phone and ask them to get onto the farm and, say, for instance, come and assist?
Okay, so this gets a little bit tricky in terms of a few things. First of all, what is the cover? So if the patient is covered on medical aid, it depends on the medical aid. It depends on who is, I see Sean's answer, and it's going to be my answer in the long term, right? But it depends on a lot of stuff. So a 40-kilometer drive to the hospital, what the medical aid are saying to us, depending on which medical aid it is it's probably better to put that patient into a car and drive them. We disagree with that completely, but unless there's a medical person with the person who's having the clinical problem, many of the medical aids are refusing to cover any activations unless it's requested by a medical person. So that starts to get super tricky. If the patient happens to be on Rocket Connect and they meet criteria, so like he's got chest pain, he's got a previous history, and he's not looking great, we'll do a super quick video call and we'll try and make a really good decision. But if he was on Connect, it would be an activation more than likely. Not on Connect, it gets a bit tricky, and it comes down to what does the medical aid accept and cover and not cover.
All right, thank you very much. Because the thing is, if I'm on the farm, I am medically qualified. So the decision will be on me.
Yeah. So if you were with him, it would be easy to justify it to the medical aids. Yeah.
Okay, great. Thank you very much, Caleb. Thank you very much.
Yeah, see, there are a few more questions. Medical aids are paying less and less each year. Will we still have HEM service in a few years? It's a really good question. And I think what needs to start happening is how do we commoditize that service so it's available to the human and not through the medical aid? And there's loads of resources and ways to be able to do that. So from a business perspective, I think long term medical aids are not going to be paying for HEMS, but there will be other options and other opportunities. And I'm going to take the opportunity to advertise because it's here and we're having the conversation. But signing up to something like Rocket Connect means that your access to a HEMS service, if you meet criteria, is really easy. And it's not an expensive service or resource. It's an expensive service, but not expensive to the end user. So something to go and have a look at. And then there's just some answers, I think, to the cost of HEMS activation, depending on single turbine or twin engine. So different services will have different costs, but anywhere from around 40 to 60,000 Rand an hour. I don't see the one for distance. Oh, I did that one already. Awesome. So I just think from my side, thank you guys for listening. If you need some sort of resources to try and make the communication with any of the flight desks a little bit better, we do have some cheat sheets and checklists that you can use when you're phoning. I think that they would make any of the flight desks better able to assist you. Obviously, we'd love if you phoned Rocket, but that's completely up to you, and please don't lose your job. And then word of the day is going to be Fly, I think. The link for the register will go out in a second. This is one of the last few coffee and cases for the year. So we have 4th of December, 11th of December, and then the 18th of December coming up, and then we're pretty much done for the year. So please think about sharing the link with friends and other people. Think about joining for the last few. I think we're going to have some really good presentations. And just as usual, thank you for your time. Have a fantastic day.
Hi, Caleb. Are you going to post those cheat sheets on here, or where are you going to post them? But
if I can probably send them on the group, yeah.
Okay, awesome. Thanks, man.
Well, have a great day, everyone.
Really enjoyed it.
The link is going to follow shortly.
Thank you. Thank you.
I'm just a bit slow today.
Mate, that's quite informative. I'm from Kenya. Thank you, man. Really appreciate it.
Awesome. Thanks for joining from Kenya. Nitch?
Hi, Caleb.
How's it?
Hi, Caleb.
Do you want to go ahead?
Caleb. Good. How
Good,
are you?
good in you, man.
Yeah. I just wanted to ask uh, the maximum flying distance for, for the hams. This edge, we can at least use fixed wing. What are the what is the distance?
Yeah, so that's also a little bit tricky. There is a point at which fixed wing becomes way faster, just because the distance gets too far. But we're not, again, we don't have great data on that. We're not totally sure what that distance is. And it also depends on the ability to land at the patient's side. With fixed wing, you need a landing zone, you need a safe strip to land on, rather than hems, which can pretty much land anywhere. So what we found is probably at around the 350 to 500k mark is probably where it makes more sense to move towards fixed wing. But again, in a place where there's no landing zone, then HEMS probably is still better. So yeah, it's really tough. So long as there's fuel on the way, HEMS can go as far as they like.
Thank you very much.
Awesome. Thanks for joining.
Thank you once again.